Assalamu alaikum. I am Dr. Javaid Iqbal, working as Assistant Professor of Neurology and Head of Neurology in Faisalabad Medical University. This lecture is intended for the undergraduate students of Faisalabad Medical University. And today, in this lecture, we are going to talk about peripheral neuropathies. Okay, let's take a scenario. This is a 34-year-old female who presented to us with progressive weakness of both lower limbs for the last 7 days, shortness of breath for the last 2 days. Weakness started in the distal lower limbs symmetrically, and then it also involved the proximal parts and upper limbs. She complains of paresthesias in hands and feet. There is a history of acute watery diarrhea 10 days back. On examination, she has a pulse of 110 per minute, blood pressure is 110 by 70, respiratory rate is 16 per minute, and she is afebrile. Further examination showed tone is decreased in all four limbs. Power is 2 by 5 in both lower limbs and 3 by 5 in both upper limbs. Deep tendon reflexes are absent, planters are downgoing, and sensations are intact. So, how we are going to proceed with this case? So, let's take what are the important features in this case. So, this is a predominantly motor lesion. As we know that sensations are intact, there are some sensory symptoms like paresthesias, but there are no sensory sign at all. So, we are talking about a dominant motor lesion. Tone is decreased, power is decreased, reflexes are diminished, planters are downgoing, sensations are intact. So this is probably a pure motor neuropathy, a pure motor lesion. So it is a paraplegia or a quadriplegia because upper limbs are also weak, quadriplegia due to a lower motor type of lesion, or this is probably a pure motor neuropathy. So, what is our differential diagnosis now of acute motor weakness or pure motor weakness? These are the common causes for the pure motor weakness. If the symptoms are bilateral, then the GBS, Guillain-Barré syndrome, this is we're going to discuss about in next few slides. And this is a demyelinative type of neuropathy, which is acute onset, or a chronic inflammatory demyelinating disease. This is also similar to GBS, but the onset is very much chronic or slow onset over 8 weeks period of time. Charcot-Marie-Tooth disease, this is a hereditary type of neuropathy, and usually the onset is very slow with years and years, and usually there is a family history. Acute intermittent porphyria. This is type of porphyria. Usually patient has history of abdominal pain, some psychiatric illness, seizures, and along with that there is a motor neuropathy or weakness. So we think of acute intermittent porphyria when there is history of abdominal pain and psychiatric symptoms. Chronic lead poisoning may also cause a pure motor weakness, but usually this is seen in patients who deal with lead pipes in the old age, probably about 20, 30, 40 years back. Pipes were made of lead, and plumbers usually do have this type of neuropathy. Diabetic amyotrophy can occur in diabetic patients, and usually this is asymmetric, involves the quadriceps, usually does not have a generalized weakness. Diphtheria, this is acute motor neuropathy. Again, this occurs initially, there are signs of diphtheria like there is sore throat and blood coming from the throat or in the sputum, followed by a weakness which generalized symmetrical usually starts after 8 weeks of the initial diphtheric pharyngitis. So there is history of pharyngitis about 6 to 8 weeks back, followed by then weakness. Paraneoplastic syndromes is actually there is a tumor somewhere in the body. As a result, there are some antibodies produced, and those antibodies cause weakness. Chronic organophosphorus poisoning may also lead to a motor type of neuropathy. Botulinum toxin, canned food used after a long period of time, and there is Clostridium botulinum in that produce a toxin which may lead to weakness and neuromuscular junction blockage, and botulinum toxin lead to neuropathy. Then the tick paralysis. In some parts of the world, there are ticks which can, when bites, inject some poisons, and that they cause neuromuscular junction blockage, and they also cause a generalized type of weakness. These are the two causes of unilateral causes. Actually, they're not typically unilateral, but they have asymmetric onset. So involvement may be bilateral, but one-sided symptoms are more predominant. So you have to remember these few things which are more important in our setup. GBS, acute intermittent porphyria, diphtheria, hypokalemic paralysis. This is basically deficiency of potassium, a familial disorder. There are defects in the calcium channels that leads to, whenever there is hypokalemia, that leads to paralysis, and usually that recovers over few hours to few days, and they that may also have a familial history. Botulinum toxin. So these are the common things which you need to remember. This is typically a case of poliomyelitis. Again, bilateral lower limb weakness, one-sided more initially, then it may involve the other limb as well. There is atrophy, areflexia, so all the lower motor type of signs. This is diabetic amyotrophy. You can see this is the atrophic quadriceps. So most of the time in the distribution of the femoral nerve, there is a lower motor type of sign. Reflexes are absent over here. It's normal over here. So usually asymmetric one-sided weakness. So what is GBS actually? GBS is an idiopathic, acute, acquired, post-infectious demyelinating polyneuropathy. So we actually at this moment do not know the cause, so we call it idiopathic, that is acute onset. We always say GBS progression can only last for 4 weeks. A patient can present within 4 weeks or later than that, but actually the weakness progression cannot be more than for 4 weeks. So maximum progression for a disorder for to label it as GBS is 4 weeks. If a patient comes to you with 8 or 10 weeks history or more than 4 weeks history of progressive weakness, it cannot be GBS. So it must be acute, less than 4 weeks. It is acquired. There is no familial history of these kind of disorders. It is post-infectious usually, and we in the further slides will know what are the pathogens which are involved in this post-infectious type. It's a demyelinating type of neuropathy. Usually, the myelin sheath of the nerves is involved, and that leads to demyelination. This is immune-mediated disease. It follows a viral respiratory tract infection or a gastrointestinal infection. Bacteria shares antigenic sites with the axons, and when immune response is mounted against those antigens, that immune response also damages the peripheral nerves and specifically the myelin sheath. Inflammation and demyelination with infiltration of the macrophages, which penetrate the basement membrane of the Schwann cells and expose the axons and cause a focal demyelination or conduction block. Inflammation causes leakage of the proteins into the CSF, that part of the nerve which is intramedullary or intradural, that inflammation of that area causes leakage of proteins into the CSF, causing raised CSF proteins. So we use this as a diagnostic criteria as well. So if we do a lumbar puncture after a certain period of time, proteins should be increased because this is usually a neuropathy or in demyelination, and no infection is there at this point in the CSF or in the central nervous system, so cells are not there. We call it pleocytosis. Pleocytosis means very less of few cells. So proteins are raised, but the cells are not there. So that shows immune risk mediated or demyelinated type of neuropathy. It may involve the peripheral nerves, cranial nerves, dorsal roots, dorsal root ganglions, and the sympathetic chain. So symptoms can due to involvement of any one of these things. So what are the common risk factors in infections? Most common Campylobacter jejuni. Many of the infections are preceded by Campylobacter jejuni, which cause GI upset or may cause diarrhea, sometimes mycoplasma, hepatitis, vaccinations, hepatitis B vaccination, cytomegalovirus, Epstein-Barr virus, and many other viruses. And non-infectious, sometimes it has also been seen after post-trauma or surgery. So classical feature, what are the classical feature of GBS? Ascending paralysis, which is flaccid, loss of deep plantar reflexes, we call it areflexia. So ascending paralysis, which starts from the lower limbs, followed by generalized areflexia and absence of sensory level or sensory signs. Sensory symptoms may be present, but sensory signs are not there. So there is no loss of sensations usually. So clinical features appear within 2 weeks after the onset of viral infections. This is a common scenario in immunological disorders whenever there is acute incitement of the immune response. After 2 weeks, there is damage to the autoimmune type of damage to the nerves or other parts of the body. It is common in autoimmune disorders. There is complaint of numbness or paresthesia. So since the symptoms may be there like numbness or paresthesias, and then followed it is followed by usually a feeling of weakness in the legs and inability to walk. So it's usually start from the leg and then patient is unable to walk. Weakness is symmetrical, beginning in the legs and ascending to involve the arms, trunk, throat, and face. So asymmetrical weakness would usually do not think of GBS at the first instance. So usually in diagnostic criteria, we'll take it should be symmetrical bilateral lower limb weakness. It starts from the legs, ascending, it may be ascending, we can say first involve the legs, then the upper limbs, it is ascending, or sometimes it involves the feet first, followed by the leg and the thighs. So it may be ascending in both ways. And it can involve the upper limbs, trunk. Throat involvement leads to bulbar palsy, like choking and hoarseness of the voice, and face weakness leads to facial weakness or facial palsies may also be there. Progression can occur rapidly in hours or days or more slowly over weeks, but it cannot go beyond 4 weeks by diagnostic criteria. So signs, there is marked flaccidity or hypotonia, there is complete areflexia, there are minimal sensory loss. It may progress to bulbar signs and respiratory insufficiency. Cranial nerves may be involved, and in some studies, up to 50% of patients may have clinical or electrophysiological evidence of the involvement of the facial nerve. So, autonomic nervous system is usually involved, and the most common manifestation may include hypotension or hypertension, orthostatic hypotension, tachycardia. Sometimes even urinary retention or incontinence may be there. Usually, this is not a very common scenario. Hot flushes, vasoconstriction, sweating may be there, but usually sensations remains intact. These are the some variants of the GBS. We were talking about the typical form of GBS. We call it AIDP or acute inflammatory demyelinating polyneuropathy. So that is AIDP. And some other variants are like Miller-Fisher syndrome when there is a dominant ophthalmoplegia, ataxia, and areflexia. Weakness usually is not a part of that syndrome, that variant. It's ophthalmoplegia, eyes cannot move up, down, right, or left. There is ataxia, patient is having ataxia, power is good, but patient still may be unable to walk due to loss of balance, and when you examine there is areflexia. So combination of ophthalmoplegia, ataxia, areflexia may be seen as a Miller-Fisher syndrome of the GBS variants. AMAN or acute motor axonal neuropathy. When you do nerve connections, there is axonal type of neuropathy rather than a demyelinating type of neuropathy, and it involves only the motor nerves. Or acute motor sensory axonal neuropathy, AMSAN. So when do nerve connections, their involvement of the motor nerves with sensory nerves as well. So this is also a variant, but this is rare. These variants are rare. AIDP is the most common. Second one is the AMAN. Third one is the Miller-Fisher, and fourth one is the AMSAN variety. So how we diagnose it? Mostly the diagnosis is clinical. So a typical patient presenting with history of bilateral lower limb weakness, which is ascending, only pure motor weakness, no sphincter involvement, preceded by a respiratory tract infection or a gastrointestinal tract infection. And on examination, there is hypotonia, areflexia, planters are downgoing, sensations are intact. So typically, this is GBS. So clinical grounds are very much important. Then the nerve connection studies. We do nerve connection, we stimulate nerve from one side, record from the other side, and we calculate the velocity. So slowing of nerve conduction, as we know that there is demyelination and damage to the Schwann cells in this disease, and the basic function of the Schwann cell is fast conduction of the nerve impulses. So when Schwann cells are damaged, there's demyelination, and basic purpose of myelination is not served. So there is slowing of the conduction, and there may be nerve blocks as well. EMG, when put a needle in the nerve in the muscle and there is get the EMG, there may be extensive fibrillation in axonal type of neuropathies. So diagnosis clinical, nerve connection most common, most important, and then electromyography may be done, and then the CSF examination. One thing important about the CSF examination is it's usually positive or proteins are increased mostly in the second week after 10 days. So if you do CSF examination within first week, there are chances that protein may be increased, but usually one should wait for at least 7 to 10 days to do CSF examination so that proteins may increase in almost 100% of cases and you can diagnose it. So increased proteins, sometimes even more than 1000 milligram per deciliter with normal leukocytes during second week of the illness. So CSF examination may be used, and some other investigations may be necessary, as we already discussed. If AIP, we need to investigate that, like acute intermittent porphyrias, lead levels, serum potassium, sometimes MRIs are necessary. So whenever your differential diagnosis is there, you have to investigate that as well. So for GBS, basic investigation are the nerve connection, EMG, and CSF examination. Management is usually supportive. Close monitoring of the vital signs, because the most common cause of death in GBS is arrhythmia. And arrhythmia is due to involvement of the sympathetic and parasympathetic or autonomic nervous system. So whenever there's involvement of the autonomic nervous system, there is intermittent bradycardia, tachycardia, hypertension, hypotension that leads to arrhythmia and that cause fatality. So most common cause of death in GBS is usually arrhythmia. So you need to monitor vital signs, the ECG very closely. Nursing care, obviously, patients has weakness, cannot move, so to do nursing care, repeated spirometries. So second most common complication which we fear is the respiratory paralysis. So for assessment of the patient, that patient is going into respiratory paralysis, you need to do the spirometries and see the patient's forced vital capacity regularly. Another method to use, if you cannot do repeated spirometry, this is the best method. But second best method may be you use a single breath count. We ask the patient to take a deep breath and then count in a single breath. Usually we say the count, for example, patient counts 30, that means 30 milliliter per kg is his estimated forced vital capacity. So more than 20, normal patients can count up to 40, 45, or 50, and you must be worried when patients counting less than 20. So sometimes, as the patient is bedridden, you need to take care of the bowel and the bladder. Patient, if there is bulbar involvement, you have to put tube, Ryle's tube or NG tube, and start feeding. You need to care for the bed sores and ventilatory support if there is weakness of the respiratory muscles. Now, the specific treatment. These are the two specific treatments which are available. One is plasmapheresis. In this, we remove antibodies. What we do actually, we remove, for example, 500 cc of blood from the patient. We centrifuge it so it separates the cells from the plasma. We remove plasma, reinfuse those cells back into the patient, and plasma is replaced by FFPs or plasma from another donor. So plasma is actually removed from the patient and new plasma is injected. So we call it plasmapheresis. And as we know, all the antibodies are present in the plasma. So if we do a single session of plasmapheresis, we usually remove 2 to 3 liters of plasma from the patient and replace it by another plasma from another donor. So we can remove 80% of antibodies. We usually do 5 sessions on alternate days. So over 10 days, we do 5 sessions. So plasmapheresis means to remove the antibodies, or other option is immunoglobulins. These are the injectable forms. We have to give at the dose of 400 milligram per kg for 5 days. So these are the antibodies which are being collected from the human blood. Actually, donated blood is there, and we remove immunoglobulins from that. We collect it. So a lot of blood is necessary for that. So they are very expensive. In our setup, if we want to infuse immunoglobulin in a 70 kg patient at this dose, that may cost somewhere between 1 million to 1.5 million, meaning 10 लाख से 15 लाख के करीब कॉस्ट आएगी इम्यूनोग्लोबुलिन की एक पेशेंट के लिए. So one thing is necessary, both these treatments are equal. We have to do only one treatment among them. One, either we do plasmapheresis or we give immunoglobulins, and they both are equal. No one is superior. This has some ease of administration because this is simple an injection and you inject into the patient. In this case, we have to place a double lumen catheter. We bring out a specific machine to the ward and do a plasmapheresis. But one thing also important is the treatment does not alter the course of the disease. So if after 6 months we take two groups of the patient, for example, one group we do either plasmapheresis or immunoglobulins, and other group we do not do anything after 6 months, the rate of recovery would be the same in both groups. Actually, these two treatments shorten the acute phase, it expedites the recovery, shortens the stay in the hospital, and sometimes shorten the complications as well. So this is necessary to do all those things. But rate of recovery is usually same. It does not alter the rate of recovery. This is a typical plasmapheresis machine. We put a double lumen catheter in the patient. Blood comes from here. It's centrifuged over here, and continuously it is infused back to the patient. What is prognosis? Mortality in good centers is around 4%, and that is due to arrhythmia, or second most common cause is respiratory paralysis. So this is the cause of mortality. 70% patients almost recover completely. 16 to 20% do have residual deficits or significant disability. It usually takes 1 to 6 months to recover. In some patients, it may take 12 months to recover. Delayed recovery may be followed by permanent neurological sequelae in axonal type of neuropathies. So those variants in which there is external damage, they may show a residual deficit. These are the poor prognostic factors. If one is having GBS with these one of these factors, that means patient will have a poor outcome. Age more than 50 years, older age group patients have a poor outcome. Forced vital capacity less than 20. So respiratory paralysis obviously leads to a poor prognosis. Preceding diarrhea. So if there is a history of preceding diarrhea, disease is more severe. There is short interval between symptoms onset and admission. So patient had symptom onset and a very rapid disease, and patient needs admission within 24 or 48 hours, and there is paralysis. That means disease is severe, so prognosis is usually poor. If there is bulbar involvement or throat involvement in the form of dysphagia or in the form of hoarseness, that is a poor prognostic sign. Or if there is preceding cytomegalovirus infection, that is also a poor prognostic sign. Thank you very much for your listening.